time is now 1 p.m. Eastern, the official start time of our webinar today. Hello, and thank you so much for joining us for our webinar series sponsored by Catlin and the Sullivan Group. Today, we're honored to have Dr. Tom Syzek join us, talking about avoidable admissions versus the death after discharge, walking the tightrope. Before we get started, we just have a few housekeeping announcements to share with you. First, today is a recorded session. We will be providing the video by either the end of this week or beginning of next for you to share or review. We are also taking questions at the end of today's recording. So if you have any, please feel free to either chat them to the organizers or submit a question anytime during today's panel. And again, we will address those questions at the end of Dr. Syzek's presentation. So if you have any additional ideas for what we might present about in the future, we would love to hear from you. You can email me at jpichet@the-Sullivan Group or info@the-Sullivan Group will also get to me with those ideas. So without further ado, I would like to introduce Dr. Tom Syzek, VP of E-Learning Solutions with the Sullivan Group and a practicing emergency medicine physician. Dr. Syzek, the floor is yours.
Well, thanks, Jenna, and welcome everyone. Good afternoon to this interesting topic that I hope to make very interesting for you. At first glance, it may seem kind of an easy, clear-cut choice whether to admit a patient to the hospital or to discharge them back to wherever they came from. Well, many years ago, this decision was much simpler. Having been in practice 34 years, it was a lot easier, where physicians admitted whomever they wanted and discharged patients whenever they thought best. Well, fast forward to today, and this admit or discharge decision has become much more complicated, kind of like walking this tightrope. Consider this as an emergency physician on the tightrope, or as my kids, I think, now call it slacklining, since it's not so tight, but popular sport. On the one hand, everyone in healthcare is feeling the pressure to avoid unnecessary hospital admissions, and for many good reasons. But on the other hand, the decision to discharge a patient home, either from the ED, emergency department, or a hospital bed, has its own consequences, sometimes resulting in medical errors and avoidable harm. So for about the next 40 minutes or so, let's explore some of the associated pressures, risks, and outcomes of this critical decision in healthcare, whether to admit a patient to the hospital or to discharge them home from the ED or a hospital bed. So here are the objectives. We'll talk about the implications of policies designed to reduce unnecessary hospital admissions. We'll profile some of the patients and conditions that are at highest risk for early death after discharge, whether just straight out of the emergency department or an inpatient bed. And then we'll explore the link between some medical errors and these deaths that occur after discharge. So as you're putting on your slackline or tightrope gear, ready to get up on the line, let's pause and take a look back at the past history or evolution of hospital admissions. So this is definitely oversimplifying it somewhat, but in the past, it was the norm that more admissions were better. Certainly better for hospitals and doctors, and hopefully better most of the time for patients as well. Hospitals were convenient. One-stop shopping served as the central location for doctors and patients to congregate and get things done. Also, hospitals were, and still are for the most part, regarded as the best place to achieve an expedited workup. Hospitals were also viewed as the gold standard location for obtaining care of superior quality, and for the most part, I think that's still true. And early on, cost had not yet become a real problem or concern. So barriers to hospital admission back in the day were low, and physicians actually developed their own code language that referred to patients who were candidates for admission or who basically wanted to be admitted. For example, code purple referred to a patient in the ED who was considered a VIP or royalty, thus the color purple. So a patient designated as code purple receive special attention, including an expedited workup and pretty much admission upon request of them or their physician. Another vernacular use was a positive suitcase sign, still used somewhat today, but not so much, referring to the category of patients who believe that going to the hospital means you're going to be staying at the hospital. They have their suitcase packed either just inside the door of their house or out on the curb when EMS personnel arrive, and they continue to prominently display the suitcase in the emergency department as a sign or expression of their expectation. And further, the Samsonite sign was a subcategory of this positive suitcase sign. These were actually in use, of course, jokingly, but they were actually in use, and you can Google them. Humorous attempts to study the likelihood that a patient would be admitted are reflected on the table on the right. This is a spoof article, spoof study, but published in the medical journal. I think it was on April Fool's Day. This fake data shows that patients were more likely to be admitted if their old chart was more than 5 centimeters thick or their age was greater than 90. Note that 7 down on this list shows that if you were recently discharged from the hospital, you were 15.8 times more likely to be admitted. Well, tuck this fact away in your head for later, because it's not so spoof related. It comes up under the Hospital Readmissions Reduction Act as a key statistic. On the more serious side, physicians did actually have the leeway to admit patients if the diagnosis was uncertain or if there was any doubt about their safety. So let's turn the clock forward to today, and the direction of healthcare, and especially inpatient care, has changed almost 180 degrees. Hospital admissions are now justifiably scrutinized as to the appropriateness of the conditions or the reasons for admission, the cost and complications that can result from an inpatient stay. So we're looking at these 3 C's I arbitrarily put together. And now the mantra is, the fewer the hospital admissions, the better. Well, let's take a closer look at these 3 C's of conditions, costs, and complications, as these are the key drivers in the movement to avoid hospital admissions. So starting with conditions, there's been a colossal shift in the location where patients and certain conditions are treated. Outpatient centers are somewhat at the basis of this, and we can now perform many services and treat many conditions that were previously found only in hospitals. Another driver for this shift was improved technology. It accounts for some of it, and minimally invasive surgery techniques, advanced anesthesia practices that result in quicker recovery. Think of your own experiences. I mean, I had major knee surgery 20 years ago. I had to stay overnight. Why? So I could learn crutch walking from PT the next morning, as if they couldn't have done that as an outpatient. But now, so many of these type of surgeries, including gallbladder surgery I've seen, outpatient, appendicitis, appendectomy, outpatient. I even kid that, and probably not so kiddingly, that coronary bypass surgery will be outpatient, and maybe with thoracoscopy it is. But in other examples include diagnostic testing that can be performed as outpatient, used to be inpatient, surgery centers and treatment centers for cancer and behavioral health. So facing an increase in competition from outpatient centers, hospitals are now investing in their own outpatient services for many years as their inpatient business declines. So the physician jargon has now shifted from code purple and positive suitcase sign to such terms as drive-through surgery, or irreverently saying, treat 'em and street 'em. Well, to be certain, most hospitalizations are still necessary and meet the main criteria, 2 main criteria, that number 1, the illness is severe enough to warrant a hospital stay, and it's also time sensitive. So the care delivered needs to be high intensity or time sensitive. Otherwise, it's elective and you could probably stay home. There are many regulations and policies in place, too many to elaborate on, but they verify the admission criteria. Entire departments have emerged to provide care coordination, utilization review. So one example of this kind of rule or regulation that can be confusing both to practitioners and patients alike is the 2 midnight rule. Most of you on this call are probably much more familiar than I am, but basically it requires that an admitted patient stay past 2 midnights in order for the hospital to receive reimbursement for inpatient care. And if they don't, then the patient is likely to be designated as an observation stay with lower reimbursement. So this has been very confusing for practitioners. In the ED as an emergency physician, my main job used to be just to figure out who's sick and who's not and where they need to go and get the best care. Well, now after I've kind of got the idea a patient needs to be admitted, here comes one of the utilization review or care coordinators, all very well-meaning and very helpful with a big book of admission criteria, and come up to me and say, hey, Dr. Syzek, I'm not sure this patient meets admission criteria, or maybe they should be observation status, or I've arranged that they could get home care for this, or documentation really doesn't support that kind of decision. So, I cringe as a clinician at that, added burden, but it's just the reality of today. So if the cost of hospital admissions was ignored in the past, it quickly became a hot button issue and still is today. So it's no secret, hospital care is very expensive and accounts for about 1/3 of all healthcare dollars spent as of 2015. This adds up to real money. That was $1 trillion annually if it was 32% of healthcare in 2015. So if we're an insurance payer, Medicare, government, or private, the cost of hospital care would certainly be on our radar and is in a big way. So it would make sense to do everything possible to avoid hospital admissions. Excuse me. So after looking at conditions and costs, let's turn to the 3rd C of to avoid unnecessary hospitalizations, namely complications. So there's increasing recognition that complications can and do develop in the hospital, with the result that a patient actually can be worse off after they're hospitalized than they were before they even came. That's bad news. So the general basket term for these inpatient complications is called HAC, which stands for hospital-acquired conditions. Some of these complications are related to poor quality of care and deemed preventable, such as pressure ulcers that weren't there when they came in and developed in the hospital. And others are related to procedures and surgeries, including iatrogenic pneumothorax, say from like central lines, and surgery-related complications. So these complications on the last slide and this slide, they're the subject of an entire webinar, but the bottom line is that hospital admission is fraught with significant risks of its own, and even more so with the spread of these deadly infections that can cause serious illness and disability, as well as death, as I said. These are healthcare-associated infections, or HAIs. They result from the use of urinary catheters, central lines, exposure to deadly bacteria, and probably overuse and overprescribing of antibiotics. And these infections are C. diff and MRSA that the public is well aware of. Surgical site infections are also under scrutiny. So just how big is the problem of infections contracted during a hospital stay? Well, HHS estimates that 1 in 25 of hospitalized patients are treated for an HAI at the estimated cost of $28 to $33 billion a year. So bad news, complication, and costly. This is what I didn't know, is that there are more deaths from HAIs than from breast cancer, car crashes, and AIDS combined. I would bet on this call that if we haven't experienced it ourselves, we know somebody who's had one of these complications occur in the hospital. Certainly not intentionally, but anyway, tying in with the issue of cost, at this point on this slide, it's worth mentioning that the complications on this and the previous slide are considered avoidable, and they also make up key measures in the safety domain of a reimbursement program called value-based purchasing for the hospitals. These complications for next year will affect 25% of the potential reimbursement from that program. So huge cost incentive to avoid these complications. Well, the cost and quality issues of hospital admissions really couldn't be more pointed than they are with this subcategory of hospital-acquired conditions known as never events. We've all heard of never events. These are events that should be thought of as rare, shocking events that should never occur. It was first described in 2001, and now this group of never events includes 29 adverse events in 7 different categories, having grown over the years. So these are yet another topic for their own webinar, but the point here is to really understand the mounting pressure that we have to avoid hospital admissions by examining the potentially negative consequences from putting a patient in the hospital in the first place. So I won't spend time listing all 29 never events, but I've listed here a few examples that might be familiar to you. Wrong site, wrong patient, wrong procedure, surgery as an example of surgical never event, contamination of a biomedical product or device, suicide in the hospital, which I have heard of and seen, when we're supposed to be protecting these patients from themselves. That's a patient protection never event. Medication errors are in there. And imagine, I mean, definitely rare shocking events, electrical shock of a patient, a burn from a patient that a patient experiences in the hospital, a surgery type of burns, or injury from a restraint. These are environmental never events. Metal in the MRI. I personally saw and treated a patient who years ago had a little pocket knife in their pocket, did not go detected, and the MRI was turned on, and it's migrated right to the area the MRI was drawing the magnetism to, the eye, and it stabbed him right in the orbit, and they brought him to the ED. That didn't happen anymore at that hospital, I'll guarantee you. And then finally, criminal never events, impersonation of a healthcare provider, and infant abduction. Well, these are the low-lying fruit and the most obvious target of the patient safety movement. If there were a hospital or healthcare equivalent of this pyramid, Maslow's hierarchy of needs, never events would really be at the bottom, the most basic need at the bottom of this period. So now back to cost. Payers, including CMS and private insurers, they understand the significance of never events, and to the point where they just simply won't pay for any additional cost associated with never events. So hopefully at this point I've led up to give you a sense of the factors behind the move to avoid unnecessary admissions, including conditions that are better treated as an outpatient, the rising cost of health care, and the specter of complications that can occur. So before we switch and talk about what happens on discharge patients, the death after discharge part of this talk, rather than admitting them, there's another important factor adding to the pressure of avoiding admissions, and that's this related issue of reducing readmissions to the hospital, which is kind of its own category. So if you recall back the tongue-in-cheek study with the few slides ago with the table, remember I said a patient who was recently discharged is 15 times more likely to be admitted if they come to the ED. Well, that was tongue-in-cheek but somewhat prophetic. This area of readmission, in the interest of quality and cost, became a big item. So a new program emerged not long ago, 2012, not long ago in my time span, from CMS in an attempt to prevent avoidable, unplanned, avoidable readmissions of patients with certain conditions, and these conditions are found to be high frequency, very high cost to the system, adding up again in real money, billions of dollars. So this program, again, most of you have heard of, is the HRRP, the Hospital Readmission Reduction Program. So the upshot of this program is that it serves to identify hospitals who have relatively high rates of Medicare readmissions and turn around and penalize those 25% of hospitals with the highest rate of unplanned readmissions. So, and those penalties amounted to $528 million in penalties in 2017. So keep in the front of your mind that to this point we're talking about issues of cost, utilization, how to reduce them. But right around the corner, we're going to be talking about issues of liability, risk, and medical errors. So just to touch on the HRRPs for just a second, here's a list of those 6 conditions this year currently targeted by Readmissions Reduction Program. Started out with fewer, and you can see 4 are medical: acute MI, heart failure, pneumonia, COPD, and recently these 2 surgeries were added, the orthopedic surgery, hip, knee, and coronary bypass. They were chosen because they're all high cost, high volume conditions. So the good news is that efforts to reduce these readmission rates, they have been successful. It's working. Rates are slowly declining of readmission since the program started in 2012. Again, just kind of a side trip about the HRRP, the readmissions program. There's been some criticism that this program, as currently constructed, is not fair to hospitals, while it's well-meaning. For example, a hospital that cares for more elderly, poor, or sicker patients, they may be unfairly penalized because of these patient demographics, and the argument is, like from the AHA, that this program needs better risk adjustment to account for that. Another criticism is that even if a hospital is successful at reducing readmissions, it still may be penalized. So imagine you get better, or all hospitals get better every year, fewer readmissions, we're getting better and better. This is a relative percentile, so that still the lower 25% of hospitals are penalized, even if you're improving. How's that fair? Well, again, there'll probably be changes to this over time, and I think there are tweaks going on. But most germane to me as a clinician and to patient safety is the criticism that hospitals really don't control what happens after patients leave the hospital. Excuse me. But I would maintain that the focus of hospitals should be on what they can control. 3 things. 1, the discharge instructions. Clarify them, make sure they're clear and understandable. Number 2, coordinate post-acute care providers, with home health, therapy, follow-up appointments, etc. Care coordination. And I'm sure some hospitals do a fantastic job at this. Others don't have the resources. This is a tough challenge. And third, though, I think perhaps the biggest impact hospitals can have on avoiding readmissions is to do a good job while the patient is in the hospital in the first place. Make sure they don't have these complications of healthcare-acquired conditions, healthcare-acquired infections, so that they won't bounce back for readmission within 30 days. Probably easier said than done. So the pressures to avoid admissions and reduce readmissions are felt most acutely where? Now in the emergency department. As this headline states, the ED is now the admissions department. More than half of hospital admissions come from the ED, so it used to be thought of as an afterthought, unnecessary evil. The emergency department now plays a huge role as the gatekeeper and the epicenter for decision to admit versus discharge. And then, are these emergency physicians up on that tightrope really have all the tools and education they needed to be effective gatekeepers there? I think medically, yes, but boy, they need some other help kind of administratively and to know strict admission criteria, the 2 midnight rule, etc. Not what they went to med school or residency for. By the way, this decision to admit or discharge is made hundreds of thousands of times every single day in the U.S. So eventually, the current trend is that hospitals will become one big ICU, that's the prediction, taking care of only the sickest patients. And low acuity cases will be treated elsewhere, as they probably should. So put yourself in the shoes of the emergency practitioner as the gatekeeper, and you're working in this environment against you. ED visits are increasing, so we're getting busier, right? Patients are sicker, higher acuity visits. And justifiably so, your primary care colleagues, when they get a sick patient who happens to come into their office, they send these patients to the ED for a comprehensive expedited workup. And I say this respectfully because patients will come in with chest pain, acute abdomen, failure, pulmonary edema into the office because they're trying to be good citizens and avoid going to the hospital. But man, this is not the place to take care of those patients. We can do things faster and get every type of blood test, CT, imaging, admission, consultation for the most part, faster than they ever could. So I'm always happy to offload patients who are really sick from primary care offices. So now keep those pressures in mind, and yet, as this headline from Harvard Business Review emphasizes, not only is your job to treat all these patients who are sicker and work them up quickly, you're also tasked with now reducing these hospital admissions from the ED. So wow, I feel the vice tightening around my head in this position. So let's stop for a minute, recap, regroup how our tightrope walker, slack rope walker is doing. She, as the emergency physician, is caring for 136 million patients every year. Patients arrive with the expectations, however, reasonable or not, that their care will be quick, comprehensive, result in high patient satisfaction scores, and no errors. So, along with that simple challenge, the emergency physician must now serve as the admissions department, and the entire decision rests on her shoulders which conditions should be admitted and which will be discharged, keeping in mind admission criteria, two-midnight rule, and the scrutiny of utilization review. Hospitalists and admitting physicians also play a part and certainly share the same pressures as they decide on the receiving end who will stay in the hospital and how long. So, granted, it's obvious that very sick patients, what's the big deal? Sick patients need to be admitted, no problem. It's not always clear-cut, though. It's not just a flip of the coin, and there is evidence-based medicine like this study to help physicians in the decision-making process. But there's a lot of other variables in this process, and ultimately it's up to the emergency physician to decide. So this decision to discharge a patient home, now we're turning our 180 degrees and looking out the door, saying we're going to discharge this patient. This has its own consequence beyond cost, reimbursement, and utilization. So on the tightrope, we're only halfway across, and now we're facing the risk of medical errors, adverse outcomes in this decision to discharge patients rather than admit them. In my own group, the ED group, where I served as chief risk officer and also president of our med-mal insurance company, we found that probably the most important decision we ever made as emergency physicians was to discharge a patient, because over 80% of all of our claims came from patients who were discharged, and only occasionally when the patients were admitted from the ED. So here's a case scenario to kind of give you an idea of the way this would go. I personally experienced this many times as an emergency physician. So an elderly patient comes to the ED. They were discharged from the hospital 1 week ago, and they had any one of the conditions targeted by the Readmissions Reduction Program: MI, heart failure, pneumonia, COPD. So I, or the emergency physician, carefully walking the tightrope, I felt the patient, they're sick enough to warrant admission. So I call up the hospitalist or the patient's primary care physician, and their feedback goes like this: "You have to tune that patient up, Tom, and send him home. I just discharged him 7 days ago for the same thing. You know I'll get dinged if he is readmitted, and so will the hospital." So the vernacular sometimes I heard was, "Tom, don't be a sieve, be a wall." Now, being an experienced emergency physician and risk manager, my response was something like, "Oh, sure, I'll send him home. And do you want to coordinate our malpractice defense now or later over coffee?" But others, maybe, with not the same background as myself, influenced by this pushback and maybe uncertain of their judgment, they discharge the patient home. Well, what's the worst possible outcome? You got it, death after discharge from the ED. Patient was found dead at home less than 24 hours later after leaving the ED. So this is the title of a journal article published in 2007, which studied, and was really one of the earlier studies, of unanticipated deaths after discharge home from the ED. Now I saw this and I thought, is this just chaos? Is there any way to make sense of this? Any risk factors, any predictive value? And it turns out that there really is quite a bit of help from some of these early studies. So this and subsequent studies began to identify certain conditions, okay? Here we're getting something we can sink our teeth into. Certain conditions that were at higher risk that got worse and unexpectedly died after discharge. Now, first of all, not all deaths after discharge are preventable, not all are foreseeable, not all are the result of medical error. So don't get me wrong. We're trying to look at those that are foreseeable, somewhat predictable, or at least at risk to do that. Well, even worse, this study concluded that more than half of these deaths of patients who were sent home were preventable and due to a medical error. So now we are tying together the deaths that occur from this decision to discharge, and that they are preventable, and that they were due to a medical error. So this is not only an issue of cost anymore, but now an issue of avoidable medical error and patient safety. And for the risk managers and insurance personnel in the room, this has huge ramifications for risk, liability, and claims. So just how big a problem is this issue of discharge from the ED? Well, the benchmarking report from CRICO in 2011 emphasized that allegations of premature discharge are common in these cases. Further, it's quantified that 41% of diagnosis-related ED cases involve inadequate assessment leading to premature discharge. A whole new category of claims that they could come up with. And most, I would relate that most ED cases are diagnosis-related, failure to diagnose or delayed diagnose. So here's the negative sequence of events we're talking about. It goes like this. A patient with a high-risk problem, not a sprained ankle, but a high-risk problem, comes to the ED. For whatever reason, the emergency physician does not adequately assess the patient, commits an error, diagnostic error, and perhaps feeling a little pressure to avoid admission, they discharge the patient who suffers an adverse outcome or dies. And the ED physician really doesn't hear anything more about it until they either come back in cardiac arrest or until a malpractice complaint arrives. Well, I struck gold and was very lucky as I was researching the topic for today, starting a few weeks ago or a couple months ago. Some very thoughtful researchers knew I was doing that and published in the nick of time this study from the British Medical Journal that just came out less than 2 months ago and gave me a gift of more information to share with you. So if you want to read just one article about avoiding admissions and death after discharge, this would be a good one. By the way, this title, it says Analysis of National U.S. Insurance Claims. These are not med mal insurance PLI claims. This is healthcare insurance claims. There's some very good information in this article, and I would highlight only a few of the findings. So this study looked at Medicare patients, millions of them, I believe, millions of Medicare patients, some of whom died within 7 days after ED discharge over a 5-year period, 2007 to 2012. So to frame it, they came up with these kind of conclusions or summaries that prior studies have yielded valuable insights, like the study I just said, patient characteristics linked to early death, and so did this study. And then secondly, they tied it to diagnostic error. This is timely. The results of this study are timely given increasing attention to the issue of diagnostic error. So these adverse outcomes after inappropriate discharge are now becoming recognized as a new type of sentinel event, something that shouldn't happen or something we should really at least research more and be aware of. Well, now we're getting something that I, as a clinician, really could sink my teeth into. This study drilled further into the specific diagnosis or conditions that were listed for patients during their ED visit. This helps us give a more clear picture of the diagnoses listed on their ED chart that were most associated with death after discharge. So here's the top 10. There were really many, many more. But you can see this list isn't entirely random. Just think about it. If you're a patient with confusion, altered mental status, dyspnea or shortness of breath, doesn't feel well or vomiting, and you let them go home without a specific diagnosis, many of them will do great. You know, they didn't have anything wrong, no problem. But some of these symptoms are red flags for serious conditions, such as sepsis, pulmonary embolism, acute MI, or other, and these are the ones that will go home and die. So these conditions, I would submit to you, are risk factors for early death after discharge. And this list could serve as a checklist, as a useful loss prevention tool for clinicians to use at the time of discharge. In other words, if I'm about to let somebody go home and say, well, I'm not sure what they have, things look good so far, but they have altered mental status, dyspnea, malaise, fatigue, nausea, vomiting, dehydration, or abdominal pain, maybe I should think twice. So the part of the study of the patients who died, they used actual death certificates and determined the 3 most common causes of death after discharge were these 3. Heart disease, like heart failure, acute MI, and COPD. All right, these are not the symptoms. These are the causes of death after discharge instructions. Now, don't spaz out, but I included this slide mostly because it was so beautiful in color and design. I couldn't avoid it. And it's not that complicated. This is an association of the discharge diagnosis from the ED, which are listed along the left. Remember, we saw abdominal pain, congestive heart failure, COPD, and the links to the later causes of death that are listed on the right. So we see there halfway down atherosclerosis, 13.6%, acute MI, and it just shows that there's a link between the symptoms or the ED diagnoses in many cases that were charted, that were linked to or somehow associated with the later cause of death. So it's not total chaos. It's not totally random. There are links. Now, this study did not make any conclusions regarding the presence of medical errors, but in my mind, certainly raises the awareness of these ED diagnoses along the left, these symptoms and conditions, as risk factors for later death. Hope you love the colors too. So the top 3 causes of death after discharge, interestingly and ironically, they're the very same conditions targeted for readmission reduction. So this is the essence of the conflict. We're avoiding hospital admissions and readmissions for high-frequency, high-cost conditions, right? MI, heart failure, COPD, and pneumonia. While at the same time, we're striving to prevent medical errors and unexpected deaths after discharge. So we want to avoid admissions. At the same time, we want to avoid harm to patients after they go home. And I'm drawing your attention to this intersection. So in addition to those top 10 things I mentioned, dyspnea, malaise, altered mental status, there is literature that shows these 6 things that are risk factors for death after discharge. These are breakdowns in process. Some of them are patient characteristics. I'm not going to go into detail for each. You'll probably recognize many of these from allegations in malpractice complaints. So, just for instance, the physician ordered a test, failed to address it before they went home. Or the patient had an abnormal vital sign, like a pulse of 125, not repeated at the time of discharge, they went home, died of a PE. Or the patient had repeated ED visits, was labeled a frequent flyer, kind of a cognitive bias, and they died of an acute abdomen at home. By the way, these are all examples of real cases. Or the patient had mental disability, mental illness, confused, under the influence, and they didn't understand a clue of what you were trying to tell them in their discharge instructions. Or they had frequent falls, and one more fall at home was the final straw. Or they had a malfunctioning indwelling device, such as a feeding tube, catheter, or shunt. Now, these are all from literature. I didn't make them up, and probably to some degree you've seen this happen in your institution after discharge. So why don't we add these 6 things to the checklist of other risk factors to be considered during a brief timeout before discharging a patient, all right? In the interest of time, I'm going to skip that piece of information and go on to the deaths that occur for patients who are in the hospital and are discharged, not just after ED. So even for patients who do not get admitted, discharge from the hospital is a dangerous transition, just like this headline points out. This was a case about a patient with heart failure discharged from the hospital with an appropriate prescription for a diuretic, metolazone. Well, the pharmacy erroneously filled them prescription for maybe somewhat similar sounding drug, methotrexate. All of us know that's not used for heart failure. It's an immunosuppressant drug that ended up killing this patient. They became very ill, bone marrow suppression, nothing helped, and they died. So the judgment against the pharmacy was $2 million, later lowered due to caps, and the hospital settled for $225,000. This was in Missouri. The medication errors are one of the most common complications after hospital discharge. Other factors contributing to adverse outcomes after discharge include these things: poor discharge instructions, because we know there's evidence to show that less than half of patients understand their homegoing instructions. Great example that I have actually read about and seen in video is at the time of discharge, the discharge nurse records the discharge instructions for the patient. So they're reading them to them, they're talking, they record it, and they place that sound file on the hospital website with a username and password where the patient can access it once they're at home, and they're encouraged to review their discharge instructions. Why not? I mean, what a great idea. So another factor is poor transitional care. The transition from the hospital to home health or extended care facility, they may be poorly documented or poorly communicated. Again, this is not indicting all hospitals. I've seen unbelievable systems working already, but these are some of the identified factors identified in studies. Also, there's typically multiple providers involved in the episodic follow-up care. You know, it's hard for patients to get this coordinated. The primary physician, the specialist, therapist, home health. Poor coordination and communication is rough. Now, here I stumbled upon something you probably, I doubt if very many of you have seen. So I stumbled upon this very interesting study by some economists at the National Bureau of Economics Research, and they put this out in November of 2016, again, a few months ago, with this fascinating and very blunt title: Should Hospitals Keep Their Patients Longer? The Role of Inpatient Care in Reducing Post-Discharge Mortality. This is heretical in this day and age. Should we keep our patients longer? What are you talking about? Don't you know about DRGs? My God. So they studied costs and 30-day mortality for patients diagnosed with pneumonia, acute MI, and heart failure. Now, this is a lengthy scholarly paper with lots of PhD type of statistical projections. But they found that one additional day in the hospital could decrease mortality rates by up to 7% for patients with pneumonia or MI. Really good thing, right? The results were not as certain for heart failure, okay? They were honest to admit it didn't work as well for them. But they concluded that the gains in mortality reduction, so the improvement in less deaths after discharge, far exceeded the cost of one additional day in the hospital. So they're basically saying we're letting patients go too soon, but they did conclude that we don't know why. The reason this finding was not given, but they suggested two things, pretty common sense. One was there was more time for the patient to be educated about their post-discharge behavior. And secondly, not rocket science, it enabled the patient to reach a higher level of stability, a nice way of saying they got better to a higher degree in the hospital. They just didn't get discharged home quite so sick. Look at the lives they could save. You know, very interesting. It's about a 30-page study. So getting to the closure and summary here, I just want to wrap it up and say in summary, we've looked at then pressures to avoid hospital admissions, including the 3 C's: conditions, costs, and complications. We also acknowledge the financial penalty or disincentive for excess avoidable readmissions of 6 selected conditions. Studies show, we've learned from some of these studies we looked at here, that there are specific diagnoses, symptoms, and process breakdowns that are risk factors. Maybe we can use these as checklists or to study or talk about in our patient safety rounds and groups These are risk factors for early death after discharge. Also, we know that medication errors, poor discharge instructions, poor transitional care, and lack of coordination of multiple providers, they contribute to early death after hospital discharge. So, if we're going to target patient safety initiatives for not only reducing readmissions, but on the same side, reducing death after ED or hospital discharge, why not target some of these? Pick one at a time. Pick some low-lying fruit. At least we are supported by the literature in the reasons for doing that. So medical errors and bad outcomes related to this premature discharge, you bet, have implications for patient safety and professional liability. So we brought this around in a circle, you know, from thinking admissions were great, let's now avoid admissions, the cost, quality concerns, and complications. Well, boy, this has huge implications for patient safety and professional liability as a result. Data from claims we showed that premature discharge are common. Deaths for premature discharge are common. And one study shows, remember, that half of the deaths after discharge are due to a preventable error, usually in failure to diagnose. And again, that's what most, I would submit, most of the claims out of the ED are related to, delayed or failure to diagnose. So this topic has been an interesting intersection for me, and I hope for you as well, of intersection of government policies, cost containment, resource utilization, none of which are inherently evil on their own, but that's on one side of the equation, and patient safety, risk, and liability on the other. So the authors of the BMJ, the British Medical Journal article, just came out 2 months ago, and it hit the press a lot too. It sums up the issue very well in their conclusions. First, that these study results have implications for ongoing policy efforts to reduce unnecessary admissions from the ED. Right? So unless extreme care is taken with selection of patients, these well-intentioned efforts could put patients at risk. That's the takeaway here. Is things are well-intentioned. We're trying to save money, give the best care, but we have to be careful about the downstream consequences, and can we help prevent adverse outcomes from those consequences as well. And so their second conclusion, they interspersed a lot about the UK in here too, about England, but in summary for the US, the policies designed to reduce overuse in the setting of the Affordable Care Act could exacerbate this problem. So this is not a political statement on my part. This is in reference to the Hospital Readmissions Reduction Act, which was part of the Affordable Care Act. So final slide is, in conclusion, what we really need is a rational balance, right? Many admissions and readmissions are avoidable, given, but so are many of the deaths after discharge, and not a small number. We need to acknowledge that the post-discharge planning and care is not entirely under the control of the hospital, and it's not perfect. And furthermore, patients will get sick after hospital discharge through no one's fault and may need hospital admission. Or non-compliance. You know, they go home, did not get their medication filled, ate a bag of potato chips, canceled their appointment, did not answer the phone, didn't let home health care in, and lo and behold, they're sick with heart failure again. I say facetiously, most patients are not like that though. Perhaps clinicians, suggestion here, both at the time of discharge from the ED and the hospital, we should consider a discharge timeout. You know, this is the critical decision. Remember, I said the most important decision time for emergency department physician is to say, you're going to go home. Big time decision. So why not use a checklist of risk factors to jolt our memory to assist in avoiding these premature discharge and medical errors? Maybe I should come up with one and copyright it, but it's certainly, you can get it out of these slides for sure. So finally, are we discharging patients too fast? Remember that economic study, and so those economists seem to suggest that maybe we are, at least for pneumonia and acute MI, okay? And that it would be not only saving lives, but costing less in the long run by reconsidering our DRG and hospital stays. So I'll leave you with those provocative thoughts. Thank you so much for your time and attention. I hope I stirred up some good controversy and ideas, and I'd be happy at this point to try and answer any questions.
Great. Thank you, Dr. Syzek, for a great presentation. We do have a couple questions that have come in, but before we address those, if you have any questions, please feel free to either enter them into the chat box or the questions box, and we'll address as many as we can before our time is up today. Tom, the first question for you, since the emergency department is now the admitting department, how can the emergency physicians educate themselves to function more effectively as a gatekeeper?
Oh boy, good one. Right, so remember I said that emergency physicians, highly trained, unbelievable job with lots of pressures, and now we've got to be the gatekeeper. So my advice is, suck it up. This is going to be part of your role in 2017 and beyond, and it has been for years. So you can't avoid it. When the care coordinator's strolling down the hallway, and they're going to question you about your admission, you've got to play ball. So I would say three things. One, become an expert, or at least more familiar with the Hospital Readmission Reduction Program. What is it? What are the 6 conditions targeted? And then secondly, let's educate ourselves, the emergency department practitioners, on the evidence-based medicine or best practices criteria for these. What are the best criteria for admission and readmission? Not just on Gestalt, which counts, but on good evidence-based criteria for MI, COPD, pneumonia, heart failure, and so on. And also, at the same time, use my checklist here of red flags for death after discharge. Third, I think, is teamwork. This can't be done in a silo. You can't really admit the patient out of the ED. You have to find somebody to admit them and agree with you, either hospitalists, medical staff, you name it. So I would say the third part is teamwork. Jenna, we've got to participate in work groups with the medical staff or the hospitalists responsible for most admissions. And we've got to recognize and realize these tensions on both sides, that while it may be in the best interest economically to send patients home and avoid readmissions and avoid getting dinged, wow, that may not be best for the patient. So I think that if you're always doing what's best for the patient, applying the best evidence-based medicine and using your judgment, erring on the side of safety, that's what you need to do.
Great, thank you. Another question, how is the situation resolved when an emergency physician feels strongly that a patient should be admitted, but the admitting physician or hospitalist disagrees?
Yeah, tough time of tension, and I have been in this situation many times. Frankly, I felt more pressure when I was first out of residency, and maybe I didn't have as much experience, and I'm up against a more seasoned or intimidating attending or one of the, quote, big hitters at the hospital, a famous cardiologist or surgeon who would disagree with me. It was difficult. But as I became more seasoned, experienced, and especially as I got into risk management, patient safety, I became more confident. And again, I always put the patient's interest first, and so I would make it a dialogue. It was never, I would say to the hospitalist or admitting physician, you and I are on the same side trying to do what's best for this patient, right? Okay, so if they disagreed with that, we're not in the same ballpark, but they'd say right. And then I would use, look, this patient does not have the support at home. They don't have the transportation they need. Home health care canceled them. There's a terrible family situation. I see the spouse there, and they say their place is a mess. They haven't got the... So I would use just logic and reasoning, social, economic, medical, you name it, to do what I thought was best for the patient. Now, in this day and age, they could be put in observation status even within the hospital, and if they were going to go past the 2 midnight rule, then they could be converted before that 2 midnights were there. But I think it's a collegial discussion. Facetiously, in the end, if I got a lot of resistance, I would say things like, look, I know what I'm talking about. You need to come down here. You can tell the patient they're going to go home, but I will come in right after you and say, that's a bad idea. You should not go home, and I'll find you another doctor. So I think there's different stages of the ways to handle that.
Great, thank you. Another question, looking at the list of risk factors for early death after discharge, why doesn't the ED physician simply do more workup on patients with unexplained symptoms?
Okay, so you're saying that if we look at that slide that had the top 10 reasons for death after discharge, like altered mental status, shortness of breath, fatigue and nausea, and your question was, why don't we simply do more workup and not send them home without a diagnosis? Well, on a practical, real life basis, this is easier said than done. It's not possible to simply do every test on every patient, and it's also not possible to nail down a definite diagnosis for every patient in the ED, as much as we would like. So the workups done in the emergency department, especially for these type of complaints, that could be one of a dozen things, these workups need to be done on a careful evaluation of every patient's chief complaint and do a good history, including the risk factors, okay? Risk factors for chest pain, risk factors for headache, risk factors for acute abdominal pain that might point you towards more likelihood of diagnosis than not, and a good physical exam. These things then dictate the type and amount of diagnostic testing. Another thing is really to avoid cognitive bias. I mean, I've got to harp on that a little bit. You know, the last thing you want to do is label the patient as a fake, a frequent flyer, over-dramatizer, a worrywart. Though you get into cognitive errors and don't know and don't self-police yourself about those kind of errors, and you are going to be a defendant, period. So that's key. And then finally, it also helps to know the highest risk chief complaints. Now, do I have to agonize over every knee sprain, laceration, ankle sprain, you know, obvious things? No. Get to know the highest risk chief complaints, their associated risk factors and complications, like for chest pain, abdominal pain, altered mental status, abnormal vital signs. Have this in a written or checklist in your electronic medical record to help assist you in your decision-making, clinical decision support, or in your pocket, and then make good decisions. So I think that's why we can't do workups on every patient, but we can focus it on those that are the highest risk patients.
Thank you, Tom. And we have one last question here. I think it's a nice one to wrap up with. So if you had to pick 3 things that a hospital should focus on to reduce avoidable admissions or readmissions and the harm after discharge, what would those 3 things be?
Okay, well maybe yeah, I'll get job offers for being the head of patient safety after this if I knew what I was talking about. So, and just kiddingly. So I think that I alluded to this in previous slides about low-lying fruit and so on. So to affect the process and outcomes that a hospital can control. Okay, so now we're talking about the hospital. There are things outside your control when the patient goes home. You know, we can't have action cams on every single patient to see what they're doing every minute. This is not Big Brother society. So while the patient is in the hospital, this is what the hospital can control. Number 1, eliminate the never events. Okay, you've got to start here. There's no excuse anymore for these adverse medical errors that should never occur in the first place. So top of my list, I'm not going to get into really obtuse details without trying to eliminate never events, okay, surgical fires, etc., bringing harm to the patient. Secondly, I think the hospital-acquired infections is a big deal, huge deal now. So I would say let's target healthcare-associated infections, UTIs, bloodstream infections from central lines, C. diff, MRSA, surgical site infections. How to do this? There's no magic. You've got to assemble the clinical leadership, administration, executives, and the influential practitioners in your hospital and make patient safety part of every meeting. You know, invite outside help if you need to, educate everybody, which you should, but you've got to start reducing these to as minimum. So now this is all still in your control. And third thing, as you asked, I would say you really got to work interdisciplinary. Okay, patients from the ED don't stay in the ED, they go somewhere, right? They go to cardiology, critical care, hospital, surgery. So let's work across all these departments, as difficult as it may sound, to agree on criteria for admissions for these highest risk entities, and keep working at it to do the best job for the patient care.
Fantastic. Well, I think that's great to end on. So for all of our attendees, thank you so much for joining us today, and thanks for your thoughtful questions. Thank you, Dr. Syzek, for enlightening us with this great controversy and thing that all of us should be thinking about. So with that, again, a video recording of today's webinar will be made within the week. And if you have any ideas that you would like to see on future webinars, please feel free to contact us. So with that, we will close today's session and make it a great afternoon.
Thank you, everybody. Bye now.